Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Lipo through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about...
Okay, yeah, okay, relax.
Welcome to my YouTube channel.
Hi, it's Dr. William, and welcome to another YouTube Live here. And for tonight, I want to go over the outline with you. There's a lot to get through. My voice is a little wonky tonight because I'm kind of getting over a cold. So the first thing I want to talk about is foams and boards. God, that sounds really exciting. Actually, this is going to be exciting because I'm going to use this little prop here to kind of show you the difference as to where the fluids we're actually treating with foams and boards and how do you treat them and all that type of stuff. So this I want to clear this up because this is something that kind of comes up a lot, and it's a difficult concept to explain. I want people to really understand why they are using foams, what is the purpose of them, why are they using boards, and where is this fluid. So we're going to talk about that. I'm also going to introduce you to a new concept that explains the hip dip and how we fill the hip dip and why you need to have a BBL in order to fill a hip dip. Because that is something that is also a little bit difficult to explain to patients. But I think with this a little graphic that I have, I'm going to be able to explain this concept. I'm also going to be releasing a new product tonight, which is really exciting. We have a lot of products in the pipeline, about 5 new products coming out to OG Recovery over the next several months. And it's really exciting. And actually over the next 18 months, there are going to be 3 other new products in the Fibergard family, which I'm also super excited about because Fibergard works so well. So I'm excited about that. Then we're going to be taking questions. I'm going to have 2 question sessions. So just type your questions into the comments. And also, if we have time, I'm going to talk about fat grafting to the breast and kind of show you how that's done, what the concept is, who it's used for, and a bunch of things like that. So we've got a lot to get through. I'm going to start right now, and let's talk about foams and boards. And I know it's really doesn't seem that interesting, but it's really important for you to understand this because it makes a really big difference to your ultimate result if you use these things properly. So I'm talking right now about after liposuction or after a BBL. So what you have to realize is what happens in the operating room is the main determinant of what your shape is going to be like. What you do afterwards is going to be the main determinant of what your skin is going to be like. And so what we want is ultimately we want you to have a really good shape, and we don't want you to have the telltale signs of liposuction, meaning we don't want you to have lumpy, bumpy, saggy skin. So that there takes a lot of work on the patient's part in order to get really good skin after liposuction. So whether it's a BBL or it's just straight liposuction, it's still liposuction. And there are things that you need to do to get really good skin. What we don't want to have happen is you end up with a nice shape and then you end up with crappy skin. We really want you to get a nice shape and also have really good skin. So you get that by following, in my opinion, this is what I advise all of my patients to do, and that is follow a protocol. Call it an OG recovery protocol. And that clearly dictates when to use boards and foams, when to use fajas, when to get massages, all these types of things. I want to focus now on foams and boards. Those are the first two steps as to what you do. So you wake up in the operating room after having liposuction, and you're going to be in your Faja. The Faja is very important for a few reasons. Number one, first and foremost, it provides compression, which can limit bleeding after liposuction. So liposuction is a minimally invasive procedure. We perform it through small incisions. We're not there with everything open and we see something bleeding and we can tie it off or cauterize it. So we rely on pressure after surgery, along with the epinephrine that we give, which is a vasoconstrictor to decrease blood flow. With those two things, that helps you to limit the amount of bleeding you have. So that's what you're going to wake up in a Faja. That's the main reason that we put you in a Faja right away. There's other things that the Faja does, and I'll go over those in a minute. Then the next day after surgery, so what we call post-operative day 1 or pod 1, you are going to wear foams and boards underneath your Faja, okay? And let's talk about the boards first of all. So where do you wear them? How do you wear them? But most importantly, what is the logic behind wearing them? Because if you understand the logic as to why you were doing something, then the whole protocol as to what to do when will make a lot more sense. And there's a lot of misinformation, in my opinion, out there, and a lot of people really don't know why they're wearing some of these things, the boards or the foams, or why they're even doing things. So I want to go through and explain all that. So here's a board, okay? It's hard. It has some foam on the other side. This is what gets worn underneath the Faja, and it gets worn right in the front. This is your front board. There is a back board that also gets worn, and this is more contoured, so it can fit better in the small of your back. So what are these foams doing, and why do you start wearing them on post-operative day number 1? Okay, so the board is not used for what everyone thinks it's used for. It's not used to get you the best shape. That's not what a board is used for. That's what happens in the operating room. That's my job. Your job is to get good skin. How do you get good skin? You start off with a board. Why are you wearing a board? To get flatter? No. You're wearing the board to do a few things. It's going to sit in the front, but the one in the back does the exact same thing. And what that's going to do is it's going to provide compression. So we're going to be closing down the space between your skin and your underlying abdominal muscles or in your back muscles. And it's closing down that space. By closing down that space, it prevents the accumulation of fluid in that area, which is called a seroma. And I'm going to demonstrate that to you here in a little bit. That's the principal job that the board is doing, is it's closing down dead space. It also will help your skin, re-drape. But that's a primary reason why you're using a board, is so that you don't get a seroma. Now, what is a seroma exactly? So, I got this little model here to demonstrate to you. And I've got a drain in here because I'm gonna explain everything to you. So, can you see this? Okay. Okay. So this is a model of somebody who's this is their skin, and so if we retract their skin back and look underneath, what do you have? Well, we have the muscles. In this case, the patient has diastasis, so the muscles are spread to show that with the tummy tuck. We have a drain in here, but don't worry about the drain right now. I'm going to talk about that in a minute. But I really want you to pay particular attention to two separate spaces. So this is one space, and this skin, in the skin itself, the thickness of the skin, the tissue, the dermis, and the underlying fat that's here, this is also another space. They're two totally different spaces. Now, when you have after your lipo, okay, you've got your skin here, and you're going to wear your board in the front to compress this. And what that board is going to do is that's going to put pressure on the skin so we get the skin to stick down to the underlying tissues. And it's also closing off this space by compressing it. Well, that prevents a seroma. Well, what is a seroma? This is a seroma. So a seroma is essentially water. It's plasma. And it's in this space here. So you see how this is now covered? This is water that's in this space. So literally free water in this space. That's what a seroma is. So it's underneath the skin. Okay, try not to get myself soaked here. It's underneath the skin, but it's not in the skin. That is an interstitial fluid. That is something else. That's one of the spaces. Remember I said there's two spaces? So there's a space in the skin, that's the interstitial fluid, and then there's this free fluid in the body. That's a seroma. So if you have surgery and you had lipo, what we want is we want the board to compress down, to close this space here so that this fluid doesn't have the opportunity to accumulate here. If it does, it's not the end of the world because it's fairly easy to treat where I can take a needle, not this one exactly, but I can take a needle and I can go through the skin and I can go in and I can actually withdraw this fluid. Now, the reason that I have the drain here is because this is the same role that a drain is playing after a tummy tuck. So, after tummy tuck, you will have fluid accumulate in here because all the little bridges that were broken when the skin was raised up, those are the lymphatic vessels. They're not going to be working. So this fluid here will accumulate in this area. And your body, I'm taking a pee on myself. The body doesn't have those channels working. The lymphatics, they're not working. So we have the drain in place in order to allow that fluid to come out. Once your body starts making and reestablishing all of those channels in the lymphatics, you don't need the drain because this fluid that's here is going to be handled by your own body. Okay, so this is the place where seroma can occur. That's the whole purpose of the board, is we want to close this dead space down, prevent the accumulation of fluid in that area, which is a seroma. And you're doing that in the back and you're doing that in the front. Now, you don't need to do it on, I'm really springing a leak here. You don't really need to do it on the sides because there typically is not an area where fluid accumulates to form a seroma. So on the sides, what we do is we're using foams. So the foams are the ones that are going on the side. Well, what are the foams doing? So the foams are doing a few things. Number one, they decrease bruising. Number two, they provide comfort. Number three, they also provide some compression as well, which helps with skin redraping. I forgot what number I am. They also are providing you with comfort, and they're also filling in any little gap between a faja or the patient's body to make it smoother and to get more compression for stopping the bleeding and re-draping the skin. And the final thing that it does that I just forgot that I wanted to, and it also will prevent you from having creases because sometimes you can get a faja. Let me tell you, I've designed a faja. I've spent a lot of time with patients and measurements and Faja, and we use AI technology for sizing, all this different stuff. So I can tell you, there is not one Faja on the market, mine included, that will fit anyone perfectly. So having some foam to go in little areas if you're getting a crease from the Faja is also a benefit from wearing a foam. So that's the main reason why you're wearing boards and foams. Well, that's great. So we stopped the seroma. But just like when you have a tummy tuck and the fluid is here, but it's being handled by a drain, once your body heals those lymphatics, you don't need the drain anymore because there's no more fluid in this area. There is still fluid here. That's a different location of the fluid, so it needs to be treated differently. In fact, it gets treated the opposite. So we keep the drain in after a tummy tuck to handle the fluid. Once your body makes the lymphatic channels, reestablishes them, your body can handle the fluid. We take the drain out. Same thing is after liposuction. After lipo, once the risk of you developing a seroma is no longer there because your body has built those channels and will handle the fluid, you don't need to compress anymore. Well, what if you continue to compress? Well, then you're actually doing yourself a huge disservice because when you continue to compress, when there's no more fluid in this area and you don't need to have that compression from the hard board, but what you're doing is now you're compressing the interstitial fluid, and that's a problem. And in my experience and my opinion, that leads to fibrosis, that leads to bad skin, which is the whole reason of why we're wearing foams and boards. Okay, let me take this little model. I'm just going to move it here out of the way here. So let me just dry some of this. I may have to can you just remove this little, I don't know where it was leaking from, but it was leaking from somewhere else here. Okay, all right, yeah, we're back in business. Okay, so the problem is when you compress too long with the boards, more than the time needed to get rid of that, to prevent that seroma, you're going to be doing yourself harm. So why? How does that make sense? How does that work? Okay, I got this to show you. So follow me along here. Oh, this is the trench. This is the trench we're going to be talking about. Okay, now let's talk about what really is going on and what really happens. These are some still photos from that Manuel did with the 3D animation that works really well. But I'm just going to go through this with you. So just follow along on, and I'm just going to explain a few things here just to get you oriented as to where we are. He's got them labeled here in the colors, but I'll just go through just to show you, and you've probably seen me do this before. This is the skin, this is the muscle, and then in between those two, the skin and the muscle, you have the fat. These are the fat cells here. And then you have other things in here that I really only want to talk about this green one, which are the lymphatics. And this is, I can tell you from a personal experience, understanding the lymphatic system the way I understand it now in 2025 compared to what I did in residency is completely different. And I take advantage of that knowledge to get better skin, because I think the most important thing about all of this stuff we're talking about, and fluid and swelling in the interstitium, is the lymphatic system. So we're going to pay particular attention to the lymphatics, but just follow along with me here. So what happens first of all when we do liposuction is we inject fluid here. So that puts fluid into and kind of spreads the fat aside. It has some numbing medicine in. It also has some things to limit bleeding. That's the first thing we do. That fluid is that free fluid that I was showing you on the abdomen. That would be the equivalent of a seroma. We're essentially giving you a seroma. So we're putting that fluid in there. And that allows the fat to separate. It makes it easy for the cannula to glide. And then we're removing the fat. That's lipo, is we're removing the fat. There's a fat going up there. And what you'll notice is these lymphatics here, they're staying behind. But they're surrounded by fluid. This is fluid here. So then, because you have inflammation, you've got a lot of things coming in after you do liposuction, a lot of trauma. So your body will bring in all of these cells. These are essentially what I call them are inflammatory mediators, because your body is healing through inflammation. And so that's the first step. And so it brings all of these things in. And then what's going to happen is, if you compress, we want you to compress at the beginning to squeeze down to close that dead space, because we don't want that fluid there. But the problem is if you continue to compress beyond the time that there's fluid, you're actually just compressing the interstitial space. So all the in between all of the cells is where the fluid is. And when you do that, that's where you lock in these inflammatory mediators. That's why I don't want you to compress for too long. Only compress for the time where the compression is needed to close down the space. After that, once that fluid is gone and the space is closed, we don't want you compressing all these and keeping all this inflammatory mediators in by closing down the lymphatic system. That's what you're doing. And we want the lymphatic system open. Well, what the hell is the lymphatic system? Well, here's a diagram of the lymphatic system. That's the problem, is it's kind of nebulous. You don't really see it when you're operating. They're clear little channels. But if you look at this here, this is an outline, and you'll see that underneath there's arteries and veins. So here's a main artery that's running down here, main artery going down to your legs, and then there are veins that go along with the arteries that are bringing the fluid back, the blood back to your body. But what happens is we exchange fluids between our arteries, between our veins, and between the interstitium. Okay, that's where a lot of business gets conducted. And what happens is, once that fluid's hanging around there, it also has to be handled and taken back to your heart, just like the veins are bringing blood back to your heart. And so this whole system of lymphatics is bringing blood back from your arms, lymphatic fluid, from your arms, from your legs, all the way up, and they're bringing it down from the head and neck, and then it goes back into the heart, and then that gets recirculated into the circulation. So that's how the lymphatic fluid gets back into your body. And if you are compressing here, then you are closing down the system, and you're trapping these little blue inflammatory mediators in there. You're creating inflammation. You're creating inflammation in the fascia. You're creating inflammation that produces scar tissue. And that's where you get lumpy skin after lipo. So compression with the board, fantastic. Close down the dead space. Prevent yourself from getting a seroma. After that time, you want the opposite. You want the lymphatic system open, because you want to get all those inflammatory mediators, all of that swelling out of the interstitial space, and that will get you soft skin. What else helps to open the system? Well, Fibergard. Fibergard is absolutely amazing, and it works from very simple principles. It has these little half spheres that then will go, and with movement and pressure, they will actually stretch and open the lymphatic channels and allow the fluid to come in. Rolling is also fantastic. I have my patients roll. I have a roller, and it goes on vibration, but you have to roll unidirectional. So if you divide, let's say we divide this body up into sort of an upper and lower. Here's your abdomen, this sort of upper and lower. So what happens is these lymph nodes are going to drain to the armpit, and lower fluid drains into the groin area. Okay, these are what we call nodal basins. These are a bunch of lymph nodes that are in here. There's a bunch in your neck. It's why if you get like a cold or something, you'll feel something because there's a little fight going on from the inflammation. So we want to open those channels up. So with the roller, I have my patients roll unidirectionally from about halfway down their abdomen. They roll to the groin. From here or this area, they'll roll up to the armpit. It's not a hard pressure roll like you're rolling out a pie crust. It's very light pressure to open up the lymphatic channels to draw the fluid in. Most people, I think, in their mind, they're thinking that they're moving the fluid out when they're rolling. It's actually not what you're doing at all. You are rolling, and that rolling is opening the lymphatics, and then the fluid follows in behind. So that's why when I have people roll, they use light pressure, and they do it in one direction, rolling to the groin or rolling to the armpit. There's also vibrational plates. Vibrational plates are very useful as well. So patients will stand on those vibrational plates, and those as well will help to open the lymphatic channels. The Faja also, it stretches, but it doesn't stretch too much. It's what's called a short stretch. And the short stretch fabrics will actually tent the skin and open up the lymphatics as well. So your Faja, you may not have considered this, but your Faja, particularly the OG Faja, where have heavy layers of very tight power net tissue that will actually provide compression, and that will open up the channels. Not the same type of compression we're talking about with this board, where you're just hammering it down. It's not that compression. With the fabric, it's a short stretch fabric, and by doing that Faja, that will open the channels, because that's what happens when you get a manual lymphatic drainage, is you're actually stretching and opening the channels and then directing the fluid where to go. You're not milking the fluid in the lymphatic channels. That's why manual lymphatic drainage massages don't hurt, because they're just soft opening up the channels. So that's your other way to do it, is MLD massages. That's a manual lymphatic drainage massages. So these are the ways that I have my patients open up their lymphatic system, activate it, get the fluid out, so that the interstitium doesn't house all of those inflammatory mediators in there to create fibrosis. All of this is being done to get you smooth skin. That's the whole goal. The whole goal of going through all of this stuff, it seems like a lot, and it is a lot. You've got to do a lot of stuff. There's a lot of things that you have to do. That's why it's important to be prepared for having liposuction, because you can't just show up, have lipo, and then like, all right, now what do I do? You've got to get educated. You have to understand, and you have to stop doing a disservice to yourself by over-compressing. We want the opposite. Compress at the beginning to prevent seroma, and then we want the opposite, because we want the lymphatic system open. An open lymphatic system is a very healthy lymphatic system. The way a certified lymphatic therapist explained it to me many years ago, the lymphatic system takes out the trash. And so you're getting rid of all of that garbage. You're moving the trash out. You're moving it to the nodal basins in your armpits, and you're moving it to the nodal basins in your groin. So it is super distracting to have somebody constantly working here, but it's also super important that you open up your lymphatic system. Okay, now I hope you understand that point. Here's another little diagram here that shows the cisterna chyli, which is kind of a big collection place a reservoir that'll go and goes right up and actually dumps, before it gets into the heart, it dumps into one of your large veins here. So it's the lymphatic system is not talked about very much, but it is so absolutely important. So, okay, I think you've got that. If you do have a question about the lymphatic system, let me know, and we can just put it in the comments, and then in a little bit when we get into the question part, I'll answer those questions. So this is just a diagram to show you the difference. This is pretty good. This here is a board, and this here is Fibergard. Why is it called Fibergard? Because it guards against the development of fibrosis. And how does it work? It works by opening up the lymphatic channels. So here's the board compressing. Everything is closed. And here everything is nice and open because we're getting the inflammatory mediators out. This will give you soft skin. Continued compression will give you lumpy skin. Okay, I think we have made that point. And I really did want to make that point because there's just so much confusion about it. And it drives me crazy when I see patients who come in and they're just over compressing, because I think they can get a much better result if they didn't do that. So, okay, now what are we talking about? Let me get onto my list here. Let me get back on track. Okay, so now this is really interesting. At least it is for me and the two other people that are out there watching this. So this is going to be talking about the hip dip, and this we're going to be talking about the trench concept, because the main thinking is I would say that I see this a lot, and I was in the office today doing consults, and I seen patients, and you know this comes up all the time. So imagine here you've got a little hip dip in your butt, okay? I give you a long butt here. So you have a hip dip here. Everyone knows what the hip dip is, right? That's your hip dip right here. So most commonly patients will say, listen, excuse me, I don't want a huge butt that's just going to not match my body and look like I had a BBL. And they don't want that. I just want my hip dips filled. I get it. Listen, I love a natural result. I like the OG line. Why do I like the OG line? Because the OG line is natural. It's a really natural shape. So I don't want you looking fake or something that just looks obscene or ridiculous or stupid. I want you to have a really nice result. So a lot of people say, okay, I don't want to be too big because I don't want to look like that, but I just want my hip dip filled in. All right, here's the problem. You can't just fill in here and then you're done. Oh, your hip dip is fixed. It's more complicated than that. And that's why I've sort of brought up this concept of this trench, because I've been seeing this for years. And what that is the hip dip doesn't just start and end right here at the hips. It actually is like a little valley or a little trench. So I have a graphic. Actually, here's a still photo that I want you to see here. So can you see my mouse over here? Yep. So this is a before photo, and you can see how she has a hip dip here, and this is her after where she doesn't have a hip dip. Well, what really happened on the inside? It's difficult to explain, but Oscar's done a really nice job of showing what that actual trench is and where there is the deficit of fat and why you can't just put fat into the hip dip. So if you look here, you see the hip dip. Let's go above here, okay? Here you are. You see the hip dip, okay, up here. And then if you go down, well, what does that look like in real life? Well, it's graphically illustrated here where you have a depression or a trench. It's not just at the outer part of the hip, but it actually extends right back, and quite often you'll see here now where I've put fat in this whole area. So in order to fill the hip dip, you need to backfill in that trench. And also by backfilling into the trench, you are providing support to the hip dip. That's exactly why you can't. And then do I have an animation here? Yes. So here's an animation. So here we are beforehand. You'll see that here's the hip dip. That's what people notice. But they don't really appreciate the fact that it goes much longer and further into the butt itself. So adding fat here will actually fill the hip dip. That's how it really needs to be filled. You can't just put a little bit on the outside. And you'll hear people say, well, I have my hip dips filled and they just came right back. Well, that's part of the problem. Part of the problem is people will say, I don't want a BBL, I just want my hip dip filled in. And then you just get your hip dip filled in. They don't backfill the trench, so there's no support to that fat. And it'll eventually just kind of bleed away and kind of just go back into that trench and backfill the trench, and you lose your hip dip. So that's why, at least in my world, I'm going to play that one more time here, because I think this really illustrates it well, or animates it well. Let's see, maybe I've gone, here we are. Because I think this really illustrates it. And then what I usually do is after I've filled the hip dip and I've filled in the trench, then I will then blend that fat into the rest of the butt. And I'll blend that fat here into the rest of the butt. So I don't ever do just a hip dip. I always do a BBL. That doesn't mean you have to have a huge volume change. We can focus on filling in the hip dip, but I have to back graft into that trench to be able to support the hip so you get a permanent result in the hip. There really shouldn't be a reason. It doesn't happen to me very often where people's hip dips just totally return to the way they were. That just doesn't happen. You can have some slight depression where you're not able to totally correct a hip dip, but that's a different problem. That's because of a tissue distensibility problem. So if you look at that, so let's just look at this sort of two scenarios here. This is just such an important point to me. So let's look at these two scenarios. So let's say you lose your hip, you lose the fat, and so you get a hip dip returns. Okay, the hip dip returns. Well, in my opinion, it's either one of two reasons. One is you never got a total fill because of the tissue distensibility. Okay? Meaning the tissue wasn't stretchy enough. So I wasn't able to completely get a total correction of the hip dip. So that's one reason that I see in my patients. If they still have some flatness in a hip dip, it's because their tissue wasn't stretchy enough to allow me to put all the fat in there that I would like to completely correct it. Because whenever I'm doing this operation, it's just a very simple, in my mind, it's very, very simple. I'm just following the OG line. So I'm just following that. If the tissue won't stretch enough to allow me to get the hip where I want, you'll have some flatness there. So I do see that problem. It's not all the time, obviously, but I definitely see it. The other problem I see is, number two, is if you had an incomplete fill to begin with. And by that, I mean that you didn't get any trench filling. So if you just had fat placed over here to fill this hip dip in, but you never had this back filling, then that fat will eventually kind of just give in and you'll have return of your hip dip. So that's why for me, filling a hip dip means doing a BBL. And this trench here is really interesting because it's different for everyone. I would say most commonly when I see this trench, and I can feel it. I mean, I can feel it preoperatively. I can feel it when I'm marking, and I feel it so that I can identify it, so that I can then fill it. So, but it's not always just sort of straight across, and it'll go down. It sometimes will go here, and occasionally it goes up. Most commonly, it's straight across in this way, but the second most common way that I see it is when it kind of goes down. And the interesting thing, too, to me, is that I don't think that'll work. If you look at it, the degree, the extent to which that goes to the middle, to medial. Medial is middle. The extent that that hip dip trench goes is also variable. So I will have people, if I just draw a new one, I will have people that their main deficit may be here that we fill in, and it may go south rather than that traditional straight across. But there's a lot of variability into the length of this. So some people it's a little bit shorter. Some people it's a little bit longer. Some people it goes almost right to the middle. And same thing here when it starts going at a different angle. Usually the upper ones are kind of short. But you can have ones that go down longer. So I really have to go through and follow. And I could feel it. And I can actually see it on ultrasound, which is really cool. Because ultrasound, when I'm doing the ultrasound, I can see when I'm in that trench because it's black, because there's no freshly grafted fat or any of that gray fat. It's darker. And so I can see where that trench is. And it's kind of cool when I'm doing it and I go through. I'll make a video on that. But I can see. And so I add fat in here all along this trench, just like in that graphic, to, depending on where the trench is, to support and build out the hip dip. So that's a really interesting concept to me, because I've been trying to explain this for a long time to patients, how you can't just fill the hip dip in. If you want to correct your hip dip, you actually need a BBL. That doesn't mean you need to be huge, but it means I have to fill in the trench. And once I fill in the trench, I'm then going to add some fat just to blend it in, because we want everything to be nice and smooth. The whole point of any of the OG that I do for the BBL or the lipo, it's following a line. And that line, the smoother it is, the better it looks. If there's no step-offs in that line, if it's just a smooth line, that's how your result is the best. It doesn't really matter if your OG line is longer and then you've got like a shorter butt. It doesn't really matter what the OG line looks like in terms of, length or more exaggerated or whatever. What I have found is if I can get a smooth line, then that is really the best result. And what I mean by that is that we're not having these sort of coming down and then you have a little bulge and then it's coming into your waist and then you're here and then we don't want that. That really looks unsightly. So we really want this as smooth as possible. And by filling in the trench and then back filling, that will get that real smoothness so everything looks really pretty and matches together. So, okay, let's take a break here. And I do have a new product that I want to talk about. It's actually the release of the product. But let's take some questions now. And let me answer these because I don't want to move on unless you're with me and you understand with where we are already. And I have some other questions that I want to get through too, to talk about it. Is this as small as you have? Oh, yeah. Okay. All right. I am 59 years old, right? Okay. All right. First of all, let me go through the geography here and point out some things. Ohio, that's great. Kentucky, Boston, Myrtle Beach, Columbus, it's awesome. Chicago, this is great. New York City, yeah, it's fantastic. And we've had quite Naples, San Francisco, this is great. Philly, I was just up in Philly. I love Philly. And we just had like an international week. Last week I had patients from down under and all over Africa and things. So it's awesome. I love to hear where people are from. San Francisco, I love that city too, although I haven't been there for a long time. Okay, let's get on with this now. Let's see. State. How long should I stay before traveling home? Also, do you have a place for patients to stay for recovery? No, I don't have a place for patients to stay. And my wife frowns upon people staying at our house for recovery. So I don't have that. But you should stay for a week in Miami afterwards. I can tell you, if you stay a week, everything will be much better for you to travel. You'll be feeling good. Any troubles that you had, if you had a seroma, any of these types of things we can already have dealt with, and you'll be ready. It's much easier to do that while you're here in Miami than for you to go home with those problems. And there's Letty. I remember Letty. A1 Body Concierge Best. A1 is super good. Really, really good people there. And they really care. Okay. Does breast augmentation have a lot of inflammation too? What garment to buy before to be prepared of coming this year? So that's really, that really gets me excited because that's about the lymphatic system. What did I do with my lymphatic system? Did I put it over here? So here's a lymphatic system. And this is something I've never talked about. This is why taking questions are just so awesome. We both learn. I mean, this is just, I wish you could like talk to me more than just here with the text, but we'll do with what we can. But breast. So I have patients where a OG Recovery Easy Bra after, it's the only sterile bra on the market. And so I put it on in the operating room when we're still sterile and the skin is all still sterile. And then the next day you change it and you put another sterile bra on. You do that every day for 5 days. It's also absorbent. It's comfortable. It's super adjustable. I use it for all my breast. So that's what I would advise in terms of wearing something. Now, the lymphatics. Would you benefit from getting a manual lymphatic drainage massage after a breast surgery? I personally would say yes. Have I talked about it? Do I advise patients to do that? No. Am I crazy about the lymphatic system and think it benefits everything? Absolutely. And the other thing where lymphatic drainage is also really helpful with is with facial plastic surgery. So face and neck lifts, eye lift, brow lifts, all of those things, noses. And my partner, Dr. Ramos, is a big advocate of lymphatic massage as well, and he recommends them for his facelift patients. And I have personal experience with somebody I've been married to for 30 some odd years who demonstrated to me very clearly after she had a facelift, and you've probably heard me tell the story, but I came home, went into the kitchen, and saw my wife preparing dinner. She's such a wonderful cook and very nice to me. That's part of the problem why I've got the weight issues. Anyway, so I saw her there, and as I just walked in, I was like, oh my God, what did you do? You really turned the corner. Like all of her swelling in her face had gone down. She's like, well, I had a lymphatic massage today. It is absolutely fantastic. This is manual lymphatic drainage is not bullshit. It is totally efficacious. It works really well. Would you benefit from having, to answer your question, would you benefit to having manual lymphatic drainage after having breast surgery? Absolutely. Do we recommend that as plastic surgeons as part of our therapy? We don't. Should we? I think we should. So if you want to have a manual lymphatic drainage therapy after you have breast surgery, it can do nothing but help you. Because if you think of what that person was telling me before, who was a certified lymphatic therapist, that the lymphatic system takes out the trash, then you've got your swelling, you have the edema, you've got inflammatory mediators, and opening the lymphatic system, whether it's in your face, in your breast, in your body, it's only going to assist you. And okay, Lisa Marie Presley's asking, currently wearing the Fibergard during the day. I'm 2 months post-op, still have a few hard lumps in my lower abdomen. Is that normal? How long till they soften up? So yes, that is normal. It's not going to work immediately. This is a very slow process because you have a lot of fluid in that tissue. It takes about a year. Yes, 1 year for that fluid to actually come out. You're swollen still at a very small level, even for 12 months afterwards. So if you have, and some people will have more stubborn tissue, but there's a couple things to do to wear the Fibergard. You have to wear it correctly. It looks like a waist trainer, but you don't want to cinch it down tight. It just has to be comfortably on. Snug, but comfortably on. And if you wear it too tight, it will kind of defeat its purpose. It'll get too much into compression. So we don't want that to be too tight. And the second thing is we want to make sure you're only wearing the Fibergard for 12 hours a day. We want some time for things to heal and the deformation that the Fibergard leaves. You look like a golf ball afterwards. We want that to dissipate, so we need 12 hours. But let me tell you a little pro tip, and this was explained to me by a by a certified lymphatic therapist, that when I this was a while ago, when I said the Fibergard's leaving bumps in all these patients, and what she did is she said, "Yay, that's great, that's what we want." Because that's showing you where the areas that are not compressed, or adjacent areas around the Fibergard spheres, that is the swelling that's in there. So a little pro tip is, after you take off the Fibergard, excuse me, I'm going to cough. After you take off the Fibergard, roll. And that will, number one, make you feel better. But it's also going to help get rid of some of the areas where fluid has accumulated, where it hasn't been compressed in between the little spheres. So I would say if you're still having a little stubborn firmness, then make sure that you're rolling. And it's best to do it when you take off the Fibergard. Okay, Letty, when do we start to use a vibration plate after a tummy tuck? I would use a vibration plate after a tummy tuck as soon as you feel comfortable enough that you're not going to fall and maim yourself. But the first few days, you're probably going to be a little bit wobbly. You're going to be hunched over. You're going to be more uncomfortable. And so it's just not safe. But as soon as you feel safe, then I would get on the vibrational plate. Anything you can do to open up the lymphatic system is going to help you. Rolling, Fibergard, massages, Fajas, vibrational plates, any of these types of things. Self-massage, if you go to your certified lymphatic therapist, you want to know how crazy I am about the lymphatic system? I'm getting certified I'm going to become certified as lymphatic therapist in February. That's how deep I'm getting into this lymphatic system. I'm deep, baby. I'm in the woods right now. I'm all about this. So if you go to a good certified lymphatic therapist and you say, "Hey, I'd like to do this at home," they will show you. And you're not going to be as good as they are. It's not a substitute. But if you think about it, if you're at home, you're always with yourself. You always have two things that you can use to help the fluid. You're only with a massage therapist once in a while, every few days, a couple times a week, whatever it is. So if you can do it yourself, that's better. And you cannot overdo it. You can't overroll. So any of these things that you can do for yourself are going to be really helpful. And if you have those little stubborn areas, stay with the Fibergard and do some rolling, get on a vibrational plate. You may want to get some more manual lymphatic drainage massages. Okay, I'll do what's necessary for best results. Yes, I love that. I'm 6 years post-op BBL. You did amazing. Thank you. That's very nice of you to say. Yeah, see, that shows, I mean, people are like, oh, the BBL results aren't permanent. And I just want to be like, you know, because it really kind of grinds my gears, as they say. And there's a perfect example. She didn't even need to say that. That's really nice of you to say. But it's nice to get the message out, because it's just ridiculous when people think. If you have, let's say, you have some traumatic injury as a child. I don't know what it is. You do something. A burn is the most common. And you burn your arm. You get a skin graft on your arm. And that skin graft takes and it survives. Well, that's it. That's permanently there. Fat in the butt or fat in the breast or fat in the face, anywhere we put it, once that fat survives, it's permanently there. The results are permanent. Okay, let's see. Let's ask for, I'm going to go through a couple more questions, and we'll get back to, I'm going to talk about the new product. MFG 9838. Hi, Doc. Any hopes for any treatments for fibrosis in the near future? Well, yes. I'm working on something, but this is not going to be released until 2027. So it's a little ways down the road. But there is something, we're still working in the early stages of that in terms of piloting it. But yeah, that's kind of the holy grail, is to get something that treats fibrosis. I recognized a long time ago that it was very difficult to treat fibrosis. I do think there are things that we're going to be able to do that's going to be able to help fibrosis. Do I think we'll ever completely get rid of all fibrosis? Probably not. But will we be able to make a bigger dent in it than we currently do? Yes. So that's coming down the road. But that's why all my efforts right now for new patients are preventing fibrosis. That's why we have Fibergard, to guard against fibrosis, because it is difficult to treat. Okay, let's see. After tummy tuck and lipo 360, how soon can you sleep on your back, normal position? When can you lift heavy objects, 30 to 45 pounds? Wow, you're really shucking some weight around there. So that lifting, 45 pounds, I would wait 6 weeks after surgery before I would suggest to a patient that they should be doing that. Because at 6 weeks, the wounds we know are strong enough, and your tissue is strong enough that you're not going to split open like a can of biscuits. But as far as like sleeping or on your back or getting into normal position, you're going to want to just listen to your body. And if you feel that you can do that, then you can do it. I mean, the way I think about these things is when people ask me, can I do it? I usually turn it around on them. Do you feel that you can do it? And then they're like, well, I don't know. I'm asking you. Well, to me, it's kind of like saying, hey, don't put your hand on that hot flame. Well, yeah, you know you're not going to put your hand on a hot flame. You're going to burn yourself. So you're listening to your own body. You know, I'm not going to do that. Same thing with positioning after tummy and lipo. If you feel like, you know what, I think I could lay on my tummy now, then it's probably safe for you to lay on your tummy. I wouldn't do any of the 45-pound weightlifting in there until you're 6 weeks. But sleeping, just listen to your body. You can start to do things, and you're not going to hurt yourself. Best lymphatic drainage massage in Miami, Lolita Lymphatic Drainage Massage. Check out their work on Google. They're the best. All right, Lolita, call me because I want to talk to you. Where's the key area located? Oh, the key area. I think I love that even more than I like lymphatics. Let me just talk about where the key areas, and then we'll get back to business here. It may actually be easier for me to show it here. Let me show it here on this before photo. You see my cursor here?
Yeah.
You guys with me? So this would be classified as the key area right here. This area here. So, and you can see that if you don't liposuction there, you end up getting a long square butt. So you have to lipo through that key area. It's right here. I'll show you one more time. It's right here, this little key area. And by doing that, that sets up the whole play. Then you're gonna then that starts to round your butt. Then you can see, once I get the key area, then I can see the OG line starting to develop. And then I'm off to the races. Oh, yes, I'm just scared that those round circles will take forever to disappear on my skin. No, they don't. They'll be gone in a few hours. And if you roll, they'll be gone faster. I think Darlene Nikki's talking about the Fibergard. Education is key. I'm all about that. Okay, let's get back. Let me talk. We'll do one more question session, but let me get back. I do have a couple other things I want to talk about here. Okay, so new product release. Drum roll, please. The new product release. It is like the old product, but new. What is this? You might be asking. Get those little emojis. So it's a new Faja. It's the same Faja, meaning it's the exact same material, same design, same compression in the key area, same 4 layers of power net there, all of those types of things. But this one is impregnated with 2 things, spirulina and also with ginseng. And both of those are antioxidants. So this Faja will actually have, when you open the bag, it'll have a smell to it. Not a bad smell. You're not going to be like, woof. No, but it has a nice smell to it. And it's because it's impregnated with those 2 things that are very high antioxidants. So again, I kind of said the other day, like, I think OG Recovery is just a skin company because we're really trying to focus on getting you the best skin. So this really fits well. It's the same manufacturer that I use in Colombia. And they've been able to do this. It'll last 25 washes. So I don't want patients kind of getting in it at the beginning because that's when there's going to be a lot of fluid and a lot of drainage, and there's not much point on having some good skin emollients that are going to help your skin built right into the Faja. There's no point getting into that right away. So my suggestion for this new Faja is to use this Faja kind of like a stage 2 Faja. Now, I'm not a believer in stage 2 Fajas because I always think Fajas should just be tight and snug and not overly tight because then we get the lumpiness. Excuse me. What's the worst thing you can do with a scratchy throat? Just talk like I do. Constantly. So I don't believe in the concept of a stage 2. But I do believe in this concept where we're having the Faja later when we're focused on trying to get good skin is when you do the Faja. So I'm recommending for patients to transition into this Faja at the 6-week mark. So 6 weeks after surgery, you're going to have most of the swelling will be gone. So it'll be very true to measurement. Size, all of our Fajas are true to measurement. So you can just look on the website and go through and you'll be able to pick the exact one that fits you. And then you've got rid of a lot of the fluid at that point and at the 6-week mark, and now you can focus on the skin. So when you're continuing to do the things to get the good skin, this is another way that will help you. And this is called the OG Faja plus skin repair. So it's the same fit, but it's going to have it, and it really feels nice inside. I don't have them available right here, otherwise I would show you. But there's a link that you can click that will help you get one or get pre-ordered or get put on a list. I'm not exactly sure exactly what that is, but they will be here soon. And if you want to be one of the first to have it, then click on the link or something. What is it? It's a code. It's a QR code. It's a QR code, and then you're going to scan that, and they'll put you on a list so that you are the first to get it. But it's called the OG Faja Plus Skin Repair. I'm really excited. We've been actually talking about this for a couple of years as to do it, and the technology wasn't quite there yet. But now it is, and so now we have it, and it lasts a long time. You'll lose the scent after a little period of time, but it's still working, and it's based on their evidence and their data. It's about 25 washes that you can go through before that material is no longer active. So I hope you try that. It's going to be really nice and to help the quality of skin. So that's the OG Faja Plus Skin Repair. Okay, I want to talk about fat grafting to the breast. Maybe this was one of the polls that we had, and this was one of the things people wanted to hear about. So let's talk about fat grafting to the breast. As long as I can keep my voice here. Now, all right, what is fat grafting to the breast? Well, it's just like a BBL, or it's a fat transfer to the breast. What can it do, and more importantly, what it cannot do? I said to someone today, and is that, you know, I always, when someone comes in for whatever procedure, I usually will point out things that I feel I may not be successful at achieving, and the patient may want that. So I think it's very important to be, at least for me, to be totally open and honest to say, I think this is possible, I think this is not possible. And I joke with my staff that I'm surprised that anyone has surgery with me, because I sometimes will tell patients so many things that they're not going to have. Because I like to be brutally honest and really explain things so that you understand what is possible and what is not possible. So I think, hang on, sorry, I'm having some technical issues. I need to blow my nose here. Can you? All right. So with fat grafting to the breast, this is really important to understand. What it can do and what it can't do. Well, what it can do is really a lot of wonderful things, but it's not the same as an implant. And so that's where I think people can go wrong, where they think, oh, I don't want to have an implant, but I want to look like I had an implant. So let me get fat grafting. It doesn't really work that way. You can't get as much volume with breast fat grafting as you can with an implant. So just one of the easiest ways to explain that is just to look at this little diagram here, okay? So I'm going to just kind of cover this up because I want to talk about that other thing in a minute. But here's a very perfect example of why you can't achieve the same volume. So if we're looking at, and I'm just going to make a little comparison chart, an implant versus fat grafting. And here we're talking about, you know, to the breast. So what can you get with an implant and what you can't, and what you can get with fat? So here, this is an example of fat, and it's come out through this little cannula here. I'm going to show you a couple other things. And this is one of the types of cannulas that you'll see here in the diagram here. And it has a little opening. I don't know, is it better to go here or is it better overhead?
Where you were.
Overhead. So it has a little opening here, okay? And that's, you see how small it is. And that's where the fat comes out. So we only can put fat into these little strands. Now, I do overlap the strands in this kind of, like you're cutting the grass at Dodger Stadium. And it goes these little checkerboard sort of lattice so that we can kind of maximize the fat. But the first thing to notice is that if we're looking at volume, then with an implant, it'll be higher. Because obviously, if you're looking at this, I mean, you have an implant that's like this. You can't put in a big glob of fat. It's not going to survive. The fat has to be in contact with the tissue in order to get a blood supply in order to survive. So you're going to have a higher volume with an implant than you will with fat. Because with fat, you're putting it in these little strands and, just like this little picture here. And so the volume is going to be less volume over here. That's one important point to understand. When do we use the fat grafting? Well, we can't use it if you really need a bigger volume change, then you're going to need an implant. But there's lots of times where you don't necessarily want a big implant size or you don't want a big volume change, but you still want to have the benefits of fat by getting more cleavage. So fat is very good for getting cleavage. That doesn't take a lot of volume, and I can specifically graft into that area here to build up some cleavage with fat and not adding that much volume. Sometimes in that area I might add, say, even 20 to 40 cc's of fat, which doesn't seem like very much fat, but it can make a significant difference to the cleavage. It's also very good for the upper pole. So it will also provide some volume to the upper pole. So for those women, if you look on their profile and they're a little bit flatter in that upper pole, they want a little bit more fullness there, then we can put a little bit of fat here that will fill in that. Not the same degree as if we had put, an implant in here. It's not to that same degree. It's more subtle, but it can be very helpful for people that don't want a huge volume change, but they want a shape change. So I will use that upper pole and cleavage when I do. Occasionally I'll do it with a breast augmentation. Most commonly I do it with a breast lift and an augmentation. That's a mastopexy augmentation. It's a lift. And then sometimes I also do it with a breast reduction. And we're adding some more fullness to the upper pole or the cleavage. The other thing that we don't really talk about very much, but I love this feature of it, is it will also transition really nicely. So what the heck does that mean? Well, transitioning is, you can have a problem if you really don't have a lot of soft tissue and you put an implant in. You can get a very round look to the implant. And some people want that and some people don't want it. Well, if you use a little bit of fat, that will help to kind of blend and soften that implant so it'll blend in more to the tissue. So that's something with either a breast lift, or most commonly, that's the reason why I use it when I do a breast augmentation, is patients will really want more of a transition to kind of smooth it out so you don't look at the implant as much. I use fat grafting quite often when we do an implant removal. So if somebody doesn't want their breast implant anymore, or their breasts are just too big and they don't want to have an implant for whatever reason, they don't want an implant, then we'll remove the implant. Now, usually we'll do a lift at that time. That's typically what's required. So I'll do that with a lift, and then frequently I'll do the fat grafting there. Because with the implant removal, obviously you're removing volume. and we need some volume in order to be able to shape the breast. So when I'm doing a lift, if there's just not enough tissue there, it can be a struggle to get a nice shape to the breast. But the fat it can't replace the total volume of the implant, but it can go a long way to giving some structure and some better aesthetics to the breast with fat grafting when we remove the implant and we do a lift. Those are the main times that I use the fat grafting. This is sort of the technique that I use. I'll see if I can kind of show you what we do. Well, let me take you back one step here. And that is, you see this little box here? So this is kind of the traditional liposuction. But this system here is called Viality. And in fact, in next month, I'm going to be filming a podcast with Dr. Miguel Medina, who was instrumental in developing this product. So I'm going to have him on a podcast. We're going to talk about it because he's a hardcore science researcher and really has some great insight and experience to share about this. But anyway, and I just want to jump ahead of myself here. This is the Viality system. It really has a couple components. It has this little sort of magic drug that he developed along with others at when he was at Harvard, and that is a little molecule that will then help to, if you look at fat cells, okay. So fat cells, they all have this kind of membrane to them. It's a phospholipid membrane. You don't really need to know all that. I don't even need to know all that.
Push the paper up a little bit.
Huh?
Push it up a little bit. Yeah.
So this is a cell membrane on a fat cell. And when you do liposuction, it's traumatic, and you can get some injury to this membrane. Okay, so you can end up having sort of like this kind of stuff. And if you have injury to a membrane, it could make this porous, and so that cell will die. And so what this molecule does in this Viality system, it goes in and it kind of, that's probably too big of a gap for it to fill in. But imagine this kind of hanging in here and stabilizing this membrane, and it increases the cell survival. And so if you have more cells surviving, you have more cells take, and you get a better retention of the volume that you put in. So the Viality data says there's 85% survival with their fat. So whenever I do breast grafting of fat to the breast, I always use the Viality system. It's absolutely wonderful and gives me really, really good fat. And then what we do is we take that fat and so when I originally get the fat, if you look at this picture here, you see how it's kind of, it's probably as you imagine fat would look. It's like kind of lumpy and fatty looking. So we take this fat and we load it into smaller syringes, and then we pass it through a series of little connectors that connect these syringes. Now this is not fat from anybody, but this is just to show you. And then you pass that into the separate syringe, and by doing this, it breaks the fat up into smaller particle sizes that will allow that fat to then flow through the cannula. And also, by putting it into little smaller pieces, it's able to establish itself and get blood supply better. So we'll take that, and there's actually different sizes of connectors that we use to process fat in different ways, and really they just have smaller kind of orifices if we look through here, and they will break the fat into smaller pieces without destroying the fat. And so, but we tend to use the bigger one for the breast fat grafting, and then I'll put it onto one of these little cannulas. This is literally, from the operating room. And this will then allow me, I could do some right here, this will then allow me to see how this stuff comes out. Yeah, it's a little tough to push. Oh, here it comes. Okay, this will allow me then to push this fat in. And so I don't go in and I don't just put a big glob in here, because this is going to lead to fat necrosis, and that's going to lead to oil cysts, and we don't want that. So you have to be quite patient and delicate, and you just push it out as you withdraw. And so let's say we were wanting to get some fat in this cleavage area. We would just put some fat right in this little area. Then I would make another pass from a different incision. It's just small incisions. They really don't leave any scars. And then I would make another pass where I then would bring in a little bit of fat this way. And then I would make another pass from up here and bring in another fat strand this way. So we end up with this kind of, little lattice structure, and we're filling all the little spaces, but we're not really overlapping any of the fat. So we're not getting like real globules in here. We don't want this. This is just going to be fat that doesn't survive and turns into an oil cyst, or it becomes fat necrosis. The fat necrosis is when, if you just imagine that little glob right there of fat, okay? Right here, we're talking about this little glob of fat. So in that area, you're going to have this three-dimensional space of fat here, okay? So that's like a little globe of fat. Well, what has to happen for this to survive is it has to have blood supply, and the blood supply has to come in. Well, if you see here, it's going to be very difficult to get blood into the center here. Whereas in this configuration, you're going to be able to get blood to all these little cells, and the whole thing will survive. So when we use the viality system, and we're taking advantage of Dr. Medina's work, and we're getting a really good survival of good quality fat that's going to survive, their membrane stabilized, we put it in a way such that it maximizes the amount of blood supply. We decrease the risk of complications. And the complications of fat grafting is fat necrosis and oil cysts. Those are two of the things, and you can get that if you're not careful of how you put it in. Now, can you get fat necrosis with this technique? Certainly you can, but it's much, much, much less chance of that happening. And what is fat necrosis? Fat necrosis is just where you get a little area of fat where it didn't get enough blood supply. Now, it got a little bit of blood supply, so it's kind of squeaking along. It's sort of like a plant that you haven't really watered very well. Is it totally dead? No. Does it look like it's doing that well? No. So it's kind of in that limbo state. And that gets fat. When that happens, your body will then put some calcium into that area of fat, and it becomes hard. So usually fat necrosis is hard. The oil cysts happen just when all the fat here, which are just cells that contain oil, when they don't survive and they die, it's something we call apoptosis, which is cell death, which this drug also helps to limit. Those cells will die and they'll release their oil, and if they're all together, you can get sort of a little area that your body walls off, becomes an oil cyst. I haven't seen an oil cyst for breast fat grafting for a very long time. I still do get some small parts of fat necrosis, and so sometimes we'll have to have somebody get an ultrasound or a mammogram after to make sure that those little areas are indeed fat necrosis and they're not cancer. Now, this doesn't interfere with cancer screening. That was the original concern, decades ago, where people were thinking, well, what happens if you put the fat in and they have fat necrosis, and how's the radiologist going to distinguish that from calcification? Because some of the precursors of breast cancer come as calcifications. So there were studies done to prove that, okay, radiologists can tell the difference between fat that's been grafting and the fat necrosis, or the calcifications that are related to breast cancer. So it's very safe to do. It's not a risk to your breast health, and it can give you a really nice result as long as you're using it in the correct application. If you're thinking, well, I'm going to get an implant, no, I don't want to do that, let me just get fat, it's not going to be the same. So fat grafting is absolutely wonderful. It has its place for certain things, and if you kind of look at what these are and stay here, you're going to be really happy with your fat grafting. If you're trying to duplicate exactly an implant, then you won't be happy with it. So I offer it to patients who I think are good candidates for it, and then I use the Viality system, and I go through and I do real meticulous work in order to get that in to survive. The other thing that also I think is important to know with fat grafting is it's repeatable. So it's repeatable, meaning you can have a second round, if you will. And back in the day where I used to do quite a bit of breast cancer reconstruction, and that is restoring breasts after patients have had mastectomies, I also did a lot of fat grafting. And the reason why I did the fat grafting is because when someone has lost their breast and you replace it with an implant, the way to think of it is like the breast is kind of like a fried egg, meaning there's sort of a yolk and then there's a bunch of the egg white. And when you lose your whole breast, you lose the whole yolk and the egg white, everything. And if we just put the implant in, it's kind of like we've just replaced the yolk. And so, excuse me, the fat would go in here. So this would be the implant. And then the fat would go in here to blend it into the tissue and to give more of that egg white. And it also works really well in patients that had irradiated tissue. And quite often we see that in breast cancer where patients will have a lumpectomy or some surgery, and then they'll also be irradiated. And they can then have that really hard woody tissue after radiation, and that can be improved with fat. So I did a lot of fat grafting with all my breast cancer reconstruction patients. But what I really noticed is this repeatable part. And that is someone would come in, we would get a result that was improved, but it wasn't as much as we wanted. And part of that was also because I was working in tissue that was irradiated, so the blood supply is not as good, the tissue is not as stretchy, it's harder to get the fat to survive. But regardless, what I learned is sometimes doing it 2 or even 3 times can really still make a benefit. And so it's not as common for cosmetic patients to undergo 3 rounds of fat grafting, but it's not unheard of to go through a second round of fat grafting to your breast. And this is particularly common in patients that have really thin tissue, so they just don't have a lot of fat. If we just look at their tissue here, can you see over here what I'm drawing here?
Yep.
So if we look, here's your skin, and then you've got your fat underneath. Well, if you really don't have much space here, then it's hard to get a lot of fat in there. And so what we'll see is sometimes we'll go through the first time and we'll put some fat into this space, kind of as much as we can. And then some of that fat won't survive, but more of it than not will survive. And by doing that, it kind of expands and builds that space up. Well, then we can go in, when we go in for a second time, and now we've got a better base to graft into. There's more fat. It's kind of like that concept I used to talk about with soil. So instead of having like a hard clay where you can't get very much fat in, if you have nice soft potting soil, you can put a lot in. And so sometimes when you go back the second time, you have a better fat bed to inject into. And so then you can then expand that and get a better result. So it's not particularly painful to do fat grafting. It is the donor site depends on where you take the fat from. If you really don't want or are having lipo, I usually do it when I do 360 lipo because that's usually the lipo I do is 360. But there are patients that don't have enough fat in their abdomen or they don't want to have total lipo around their body. Then what I can do is I can lipo on the sides of the breast. It's quite often there's fat there that's helpful that patients don't want anyway because of the bra fat, and then I can use that fat and then graft that into the breast. But we can use fat from anywhere in the body. It's common, I think, in the reconstructive world for patients to have some fat taken from the inner thighs. I'm not a big fan of that because that can leave some irregularities. So I'll usually prefer to take it from the side of the breast, or I take it if we're doing just total 360 lipo, which is most commonly what I do. Okay, I'm gonna take more questions now, and then I think my voice is kind of waning a little bit here. So I'm gonna take some questions, and then I think we'll wrap it up at that point. Okay, so what am I doing here? These are the questions. My goodness. Okay. All right. So I guess if I go to the bottom, those are going to be more current. Is that right?
Yes.
Okay, MMD is asking me about fluid and a feeling of tightness after breast reduction. So anyway, well, let's talk about breast reduction for a moment here. And I don't use a drain when I do breast reductions. Way back when I was taught to perform a breast reduction, I did use drains because that's how I was taught. But there's really not a lot of lymphatic fluid that's there that needs to come out, and a drain won't prevent getting a hematoma. So I don't use drains when I do a breast reduction. Do you want me to push that here? So I don't use a drain when I do a breast reduction. I don't know exactly about the tightness feeling that you're talking about. That's not particularly common in my experience for people to have a really tight feeling. But it would be a little bit unusual. I would just talk to your surgeon and see what they say. But the tightness is not something I come across too often. Bronze Bash Hall. There's a #1 crown. I don't know what that means. I wanted recommendation on things to use for scarring too. Sure. I mean, everything I have is OG. So I have the OG Scar System, which is a very simple 2-step process where you massage the silicone gel, it's a scar gel, into the incision. You do that twice a day for 2 minutes, twice a day. And then at night, you wear silicone gel scar strips, and they're reusable. So I have a very simple system. It's called the OG Scar System. And the thing that's really unique about it, and you may think this is kind of funny, but the thing about it is, do we have one kicking around somewhere? The thing about it is the bottle is specifically designed for using the gel properly. So the main, it's wonderful. God, ask and you shall receive. Thank you. Okay, so here's the gel. Now, obviously the product is important. What's inside the bottle is important. And there's silicone here, silicone gel inside. But equally as important is how you use the gel. So if you look at all the gels in the pharmacy or creams or ointments or whatever, all of them will come in a tube or some type of little container where you're going to squeeze it out and then you put it on your scar. All right, well, we've known for literally decades that the most important thing about getting the best scar is the massage. So when I created the scar gel, I wanted it to come in a vehicle. Actually, I had really fancy designs for a very ergonomic handle with impressions and everything like this. And then everyone told me, like, yeah, you can't do that. There's nothing on the market that's available, and that's going to cost you $10 million to design it. So I said, okay, well, what do you have that I can use? So it took a while. It actually took about 12 months. Poor Ivan was able to procure this type of delivery device. And so it's not trivial. This is really very, very important. So it vibrates. You turn it on the bottom. This one doesn't have a battery. You turn it on, it'll vibrate. That's helping with the lymphatics. And it also has this roller ball, which will allow you to massage it. Am I passionate about this? Yes, I am. Does it work? Absolutely. But you have to do it properly. 2 minutes twice a day. And you have to massage for a whole year. Yes, a whole year. But what you're going to do is you're going to put this on in little circles and you're going to push. There's going to be some force here. Now, this is obviously not causing me to cry, but I feel it. It's not just taking it out of the container and putting it on. That's not going to be effective. It's a little effective, but not that effective. It's like me, I'm just a little stitious, not superstitious. So what happens is you're going to go in a line and you're going to go in little circles. And it's the massage combined with the silicone scar gel that's really helping. And then at night when you're sleeping, you wear a scar strip, which keeps silicone in contact with the wound. So, is there something to use for scars? Yes, there is. Oh, somebody said get well. Oh, that's Letty. Letty, you're becoming my favorite here. Thank you, Letty. Did anyone else use steroid cream after BBL? I would not recommend using steroid cream. The only time I ever prescribe steroid cream is I usually don't prescribe it. I usually use over the counter, but there are patients that will develop rashes that don't respond well to the 1% hydrocortisone or 2% hydrocortisone over the counter, and so I'll prescribe them a stronger steroid. But you have to be careful with steroid creams because they can thin the skin. So I personally would not recommend using steroid creams. Okay, oh my God. Naisha Rivers, 8550. Can I get IV iron instead of taking the oral pills? If so, how soon before surgery would you recommend me get the IV infusion? So this is really interesting because I've been looking for the last 2 weeks for a good solution for this because there was a paper that was just published in our journal talking about is compared using an IV iron infusion. It was done in Italy. And I was comparing an IV iron infusion to a different type of iron that's more of a dissolvable one. And they found that patients undergoing liposuction had a much higher ferritin level and a much higher hemoglobin level after liposuction if they gave patients IV iron. And it was a single dose, 1,000 milligrams, and they gave that 3 days prior to, I think it's 3 days prior to surgery. I was just reading it the other day. It was a fascinating article, and I wrote notes on it, actually. I always do that when I get a really good article that I really like, I take notes on it. I don't know where they are. Let me see. I don't know where it is, but I think it was 3 days before their surgery, and they found, and what they actually said in there, and I thought this was really an interesting comment, and it's something I've noticed myself, but I've never really kind of put it together, because I'll have some patients who the lipos aspirate, what we're removing to the lipo, is more bloody than other patients. Sometimes I even have to stop and I'm unable to complete the lipo. It's not very common, but there's variability. And sometimes I've had patients, and there's really been very little blood loss that I can see, and they've required a transfusion. And other patients, you think, oh, gee, this is going to be a difficult recovery here. And they never require transfusion. And the authors in this article, this Italian article, said that they think that the need for transfusion is based more on the patient's red blood cells and the ferritin levels than it is on the actual volume of liposuction. I thought that was really interesting because I've kind of know some of the same things. The problem, and so I wanted to look into this to see if I could do this for my patients. The problem is it's extremely expensive to use this IV therapy. But I would say that if you can get access to IV therapy with your hematologist, then I would say getting it done closer to the surgery is probably better based on that study. I don't have any other experience to recommend that. I haven't done a deep dive to go through to look at all this because once I found out that it was going to be cost prohibitive, I kind of stopped. But that's really interesting that you would ask that question. And usually it's done in a hematologist's office because there are a couple of issues with it. You can develop anaphylaxis. So if I was doing it, I really wanted to do it in my office, but I would have done it 3 days before surgery. But then we would have you under observation so that if you did have an anaphylactic reaction, which would be very rare, but it's still possible, we would be there to help you with that. So that's a great question. Thank you for that question. Let's see. Is it okay to use weight loss injections before surgery? If so, when should I stop? Yes, it is good to use them. If you're overweight, if you have internal fat, then they're beneficial to use them. I have personal experience with them, and I think they're fantastic. But you're going to want to stop 2 weeks before surgery because they can slow down your gut motility, meaning they can allow fluid or food or liquids to pool in your stomach and slow it down. And so we would keep you NPO before surgery, but then you're actually still not safe because there's still food there because it's been delayed. So stop it 2 weeks prior to surgery. Yes, Capricorn Empress, you're asking me about Exparel. Exparel is something that I'm very familiar with. I was actually, when it was originally released, probably, 15 years ago, I would guess, we had to take sort of like a certification process at the hospital in order to use it. And it's just what it is it's a long-term acting local anesthetic. So let me tell you so I'll see if I can draw something like that. So what we do is we have lidocaine. That's a typical local anesthetic. There's a whole bunch of canes. There's lidocaine, bupivacaine, novocaine, tetracaine. All the canes. They're all local anesthetic family. And then there's another one called bupivacaine. And this one here, let's do this a little green. So the bupivacaine, the way it comes when you package it as Exparel is it's got some other things attached to it. And these things are what we call lipophilic, meaning they love fat. So when you put this little bupivacaine molecule inside this little Exparel package, this will then go into your fat cells and it slowly releases the lidocaine and it can give you long-term pain relief. So it's a great drug. The problem is, the reason why I don't use it is whenever I'm doing things, most of what I do is involving some type of liposuction. So whether I'm doing a BBL or lipo or a tummy tuck, I will usually use lipo with that. And when I use liposuction, we're using lidocaine. And lidocaine actually likes these little purple things more than the bupivacaine does. So what the lidocaine can do is come in and it'll bind to all of these and it'll knock off the bupivacaine. And so then you'll get an overdose of bupivacaine and die. So Exparel is a great drug. It's been out for many years. It's very safe. It's very useful for certain things, but you can't mix it with the lidocaine, which is why I don't do it. If I do a pure tummy tuck and I'm not going to do any lipo, then I can inject Exparel, and that will give long-term pain relief. So it can be very good. It's just not that applicable for my practice. Oh, Letty, I can't even tell you about the dumplings. Okay, your surgery's in May. Well, Capricorn, you're like on top of this. You're a type A personality. Okay, Alia Denning is asking, how soon can I use a scar kit with a breast aug? That's a good question. I didn't mention that. So I have all my patients start their scar care 3 weeks after surgery, because that's when you get this concept of the healing ridge. And so my kids would always be where they ask me for their help with their homework. I'm like, all right, let me go get some paper. They're like, oh God, this is gonna take forever. Whenever I got the big paper out, they knew they were in for it. Yeah, that's probably why they stopped asking me. So at 3 weeks after surgery, you have the healing ridge, okay? But I like people to understand things. That's why I get the paper out. I want you to understand this. So I know that you can say, I could have just said 3 weeks, and I've answered your question, and we're moving on. But I can't. I just can't do that. I'm not capable. Unless you understand what I'm saying, I'm not going to stop. I'm relentless. So here's why I have you start scar care at 3 weeks, okay? It's because of the healing ridge. What is the healing ridge? The healing ridge, if you have an incision here, okay, this is your incision, and then I come along and I take this end and I sew it to this end. Now you have this piece connected to this piece here. We bring these two things together. Now your wound is closed. Okay, what happens? A lot happens at this point. This is kind of like the air raid alarms going off. Like, I can't do that with my voice. But you know that air raid sound. God, if we had somebody that could make an air raid sound thing on the board, so when this happens and this comes together, the air raid sirens go off, and there's a whole cycle of events that then start to happen. That's the wound healing cascade. And so it sets into motion a lot of things. By and large, the way to think of it is you have a ton of cells coming into here that are all there for the specific purposes of healing that wound. And when the cells all come in, they start to heap up, and it starts to get this lumpy area, and it's called the healing ridge. It happens in the line where you get this, where you have the trauma, if it's a dog bite or surgical incision or whatever. So you get this healing ridge of all these cells. Now, at 3 weeks, your wound is strong enough that you can start to massage. And so that's why I do it at 3 weeks, because you have the healing ridge, and now you're just going to wait for time and start your massage, and then wait for that to gradually flatten. Because you want to get a good scar. It should be flat, it should be thin, and the color should match. And you do all of that beginning at 3 weeks, so we're treating the healing ridge. It's why people typically will freak out and call the office. I guarantee you, 100 people call plastic surgeons throughout the entire United States today saying, hey, I think something's wrong with my wound because it's very lumpy and bumpy and it looks red. I think I'm getting an infection. You're not. If it's at 3 weeks, it's because of the healing ridge. Because the healing ridge will look lumpy, bumpy, and red. So, okay. 2 more questions, and then I think I'm out of breath here. Excuse me. All right. Jennifer, thank you for saying that. That's very nice of you. But I guess if you grew up with having me as your father, you'd probably get tired of that teaching after a while. They would always tell me they have other subjects that they need to do. I'm like, yes, but you have to understand how this electricity is flowing. V equals IR. Okay, let me take 2 more questions, and then we're going to hit the road. In a BBL 6 months, I was curious. This is great. Sorry, I didn't follow that. Oh, that must be referring to your other one. Okay, wellness veggie. If someone has stretched breasts with thin skin, grade 3 to 4, what breast procedures are recommended? Okay, that also is a topic near and dear to my heart, because for patients that have really poor quality tissue, it's usually not just your breast tissue, but it's also the ligaments that are supporting. If you look here, let's say, if we look at a breast that's sitting against the chest wall, right? There has to be something supporting that breast, holding it to the chest. Well, that's fascia. And so there are little kind of attachments that go from your breast to your chest wall. That's your chest. Okay, that's your chest wall. And these ligaments here, they have different names, ligament of Spence, Cooper's, and circummammary, and things like that. So these ligaments are really what are doing most of the heavy work. A lot of people think it's the skin, and you can see the skin is poor quality, or you can see the skin is good quality. You can't see the ligaments. But it's been in my experience that if the skin is not good, the ligaments are also not good. And there's things that you can do to help. So number one, if we're talking about, let's say, a breast lift, so a lift with an implant. So if we're talking about a lift with implant, there's a few things that we can do that will help with someone that has poor quality tissue. Number one is the size of the implant. If you can keep the implant size smaller, it obviously decreases the amount of force and traction on the breast and will help prevent redrooping. Number two is just the lift itself will remove some of those damaged ligaments. And by removing some of those and reshaping it, that can help. And number three is you can use what's called an internal bra, which really is, for my world, it's either mesh or stratus. Stratus is a pigskin, and mesh is a synthetic mesh, very much like, kind of looks like the material you'd have on a window screen, you know, that kind of see-through sort of thing to keep mosquitoes out. It looks like that. It's made up of the same material that some stitches are made up, so it dissolves. The stratus is a pigskin, and that will eventually get replaced, but that takes much longer. Both of these are very good. I use them under different circumstances. They both are doing an internal bra. That will help to support the implant. If you look at it from the bottom, the internal bra is sort of going in this area here like a hammock. And it will help with the implant, to support the implant. And if you looked at it from the front, this is your breast here. It kind of it runs like this. And that's the internal bra, either mesh or stratus, and that will help support the implant. And then the other thing to know is I will call patients that have really poor quality skin and therefore ligaments. I will call them a rapid redrooper. That's just a term that I came up with quite a few years ago to identify a group of patients that I think are at high risk of, after having a breast lift with an implant, within 6 months or a year, they will have most of their droop. And if you look, can you see up here?
Scooch it down.
Scooching.
Yeah.
All right. So if you look at the time and the amount of droop, okay, droop over time, what happens is most of the droop after your surgery, if you have a breast lift, happens quite quickly. And that would be within the first 12 months. And then you still droop, but you tend to droop much at a slower rate over time. So you'll eventually droop, but it'll just be much slower. So for me, if I see someone that has very poor quality tissue, and I think that they're going to droop quite quickly despite doing some of these things, then what I'll do is I'll say, hey, you are what I call a rapid re-drooper. And no one likes to hear that, but I would rather tell you up front than tell you at 12 months, oh, you're a rapid re-drooper. Yeah, you re-droop. So those people, I think, will have a bigger sort of slope to this and a faster descent. And so even by 6 months, they can have some bottoming out. And the way that looks is, let's say here's your breast, and now with bottoming out, you can have some lengthening of this lower pole here. And when that happens, it kind of moves the nipple up higher. And that's that bottoming out. And that's that stretch. And that's because the ligaments aren't that good. So what I usually say to those patients is, it's not the end of the world, but you will have to have most likely a revision at 6 or 12 months. I like to try to wait 12 months if I can, to where we go through and we'll redo the lift. It's not a total redo of the lift, but we're getting rid of some of those weak ligaments and poor skin. And usually we can get them back to where they were at the beginning before they redrooped, and that way they'll have more of a stable result and they're not going to do this quick droop again. So that's what I do for weaker skin is or ligaments, is identify the patient who has it, tell them, hey, I think this is an issue for you. I suggest using a mesh or stratus and keeping the implant on a smaller, more reasonable size, and those things can help you. But hey, you might need a revision of the lift down the road. And I think going into it with eyes wide open is the best way. And when people have done that, and I've done revisions, they end up being happy. But they wouldn't be happy if I didn't tell them that at the beginning. So, okay, I'm going to wrap it up here. I don't know where the time went, but it goes fast. Probably with me just blabbering on. Scan the QR code if you're interested in that new OG Faja Plus Skin Repair. It's really, really nice. It's going to be helping out patients' skin. So make sure you jump on that. And stay tuned. We have other lives. Dr. Carriega is going to be doing a live shortly on my channel, as is my partner, Dr. Ramos. Both excellent surgeons, and they're going to be worthwhile to watch those. And we also have another announcement. BTM 6 is coming out.
This November 30th.
November, the end of this month.
Yeah.
BTM 6 is coming out. I filmed it, but that's the person that's editing and releasing it. And so BTM 6, if you don't know what it is, called Behind the Mask, Season 6. So yes, this will be the 6th season we're doing this. And there are some really good topics. Our opening topic is
The trench.
the trench. So I'm going to be talking about the BBL, and you're going to see some more of those graphics and more of the animation to really explain. And I'm showing you in the operating room as well. And I also have some footage of patients in the exam room, so you can really kind of get a handle on what this trench is. So that's going to be coming in episode 1 of season 6, Behind the Mask. And then we're going to have some podcasts, Behind the Mask, the podcast. Those are going to be coming out as well, where I'm talking about post-operative depression. That's a really good one. And we're going to be talking about rhinoplasty. There's a lot of things coming down the road. And then there's going to be products coming. Probably the biggest one is going to be coming at the end of January, which is going to be a product designed to help fat survive after fat grafting. So a lot of stuff going on. I appreciate your support. Subscribe to my channel if you're not already a subscriber, and turn on your notifications. That way you'll get notified of these live. Sometimes I do them without as much warning because it just fits in the schedule. But thank you very much for watching. Thank you for support. Thank you for the questions. I really like the questions. I always learn something, and I really appreciate that question about the IV iron therapy tonight as well. So thank you very much. Have a great night. I'll see you soon.
Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Lipo through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about.
Okay.
Yeah, okay, relax.
Welcome to my YouTube channel.